Okay, time of the lecture started. Good afternoon, everyone. Um, we need to start our lecture. Uh, Today we have the theme about pathology of the retina and the optic nerve. Uh, Firstly, you need to read the message in the comment chat. Don't forget that attending lectures is mandatory for our students, for all students in our institute. And for those who had classes, practical classes, and for those who will have them after finishing lectures. So don't please tell your colleagues, tell students of groups to come to the lecture. Don't forget to come to the lectures. Okay, let's start with pathology of the retina. And здрасте. Guys, tell me please, do you see something on the screen?
Yes, routine.
You are now unmuted.
Because
You are now
I
muted.
have problems with visualization.
Mm-hmm.
1 second, please. I'll try to open other version of lecture. Okay. I think you see. I think you see the first slide with the anatomy of the retina.
You are
Yes.
now unmuted.
Good. Thanks.
You are
Let's
now
start.
muted.
What is retina? Please repeat. Remember that the retina is the inner layer of the eyeball wall, the peripheral part of the visual analysis, of course, and there are three first neurons in retina of the whole visual analyzer. It is something like the window into the brain. The retina consists anatomically of 10 layers, not 5, not 2, not 3, but 10 layers. In the outer photoreceptor layer, there are two types of photoreceptors, cones and rods. They have its own specific. Um, Rods work mainly in dim light, cones work in well light. Rods provide black and white vision, cones provide color and central vision. What about blood supply? It goes from the central artery of the retina. And also, it is very useful information, retina has no sensitive innervation. So there is no pain if there is inflammation in retina. The next slide, main functional areas of the retina. Anatomically, we have two main central areas. It's macula. Macula it's oval-shaped yellow spot, in the center of which there is a vascular free zone, fovea. It is a place with the highest concentration of cones. It is a place of higher visual acuity. Also, we have optic disc in the fundus. Optic disc is a point of exit for ganglion cell sections leaving the eye. Optic disc is also the entry point for the major blood vessels that supply the retina. Optic disc normally have yellow, pink, or pale pink color, clear borders, and round or oval shape. Okay. The optic nerve. Optic nerve, is also known as cranial nerve number 2nd, and it is a paired nerve that transmits visual information from the retina to the brain. It's formed by the axons of the retinal ganglion cells. It has several parts, but you know this information from the anatomical lecture. And we start the clinical features from the first disease. It is hypertensive disease, and there are different changes in the fundus in this hypertensive disease. Depending on the severity of the clinical course, there are four stages. of development of hypertensive changes in the fundus. The first stage, it is hypertensive angiopathy. The second, angiosclerosis. The third, retinopathy. And the fourth, hypertensive neuroretinopathy. And one by one, we will describe them. The first, hypertensive angiopathy. Clinical picture here, arteries slightly narrowed, veins dilated and convoluted. In the macula, there is a symptom of a GVIST. It is corkscrew-like tortuously of small venous vessels. It is in the central part in macula, very small arterioles become and arterioles and venous become such corkscrew like tortuosity. Okay, the changes. Sorry. The changes are reversible in this stage if the situation with blood pressure is stabilized. If it is not stabilized and become progress, the changes goes to the next stage. But firstly, we look to the changes of hypertensive angiosclerosis. You see here very wide veins. They are very wide, and also you see the arteries which are slightly narrowed. And there are no another signs. In the next stage, hypertensive angiosclerosis, we see the next clinical picture. It is thickening of the walls of the arteries and deposition of lipids in them, the symptom of silver wire. A symptom of arteriovenous cross, you see this symptom in the picture. It is symptom named by Salus and Gun. Salus-Gun symptom has three main stages. The first Salus, it is when artery crosses the vein and slightly press it. The vein appears thin on both sides of the artery. The second stage of Salus the second. The vein before the cross bends in further of an arc and sharply becomes thinner in the zone of the cross. And the third of the Salus-Gun symptom, when in the area of the cross becomes invisible as if interrupted. The next stage of hypertensive disease inside the eye, it is hypertensive retinopathy. Hypertensive retinopathy, its features are the change develops in the retinal tissue. It appears patchy opacities and hemorrhage. Appear of white ischemic cotton wool-like foci in the retina. In macula, whitish or yellowish lesions and plasmaria are grouped in the shape of a star. And could be macular edema. The next stage is hypertensive neuroretinopathy. The optic disc is plus to the retina with edematous features. So the optic disc is involved in the pathological process. In addition to just name changes, it becomes edematous, enlarge, appear hemorrhage. The optic nerve atrophy can be the outcome of this process. As for treatment of hypertensive changes in the fundus, is primarily general and is carried out in conjunction with the therapeutics and cardiologists because it is secondary changes due to the main disease, hypertensive disease. The next severe disease which cause changes on the fundus is diabetes and diabetic retinopathy. It develops 5 or 7 years is a second variant of diabetes, or 10-15 years is the first variant of diabetes. After the manifestation of diabetes steadily progresses, affects up to 90% of patients. What about clinical picture? There is a defeat of the venous capillary system of the retina, choroid, and iris, development of red blood cell aggregation, formation of microaneurysms, vascular obliteration, as a result, problem with tissue respiration. And we have the fundus ischemia, and as a result, neovascularization. Neovascularization, vascular thrombosis as a result of neovascularization, and development of red blood cell aggregation. Hemorrhages and focal opacities in the retina also develop. Diabetic retinopathy also has different stages. The first stage is non-proliferative, the second pre-proliferative, and the third proliferative retinopathy. The first stage, characteristic diabetic changes, microaneurysms, small point hemorrhages, and hard exudates. In the pre-proliferative stage, the appearance of foti of soft exudates is characteristic, white ischemic cotton-like foti in the retina. And the last and the most severe stage of the diabetic retinopathy is the proliferative retinopathy. In the later period, the formation of new vessels, proliferative processes, retinal fibrosis, with the development of traction syndrome, and as a result of retinal detachment are noted. Preretinal hemorrhages, retinal vein thrombosis are formed. It is the most severe stage, and it of course needs special treatment. As for treatment of diabetic retinopathy, of course, firstly, we need to make compensation of diabetes, normalization of blood glucose levels. We must do it firstly with endocrinologist. As a specific treatment, we use laser coagulation of the retina. It can be started in the pre-proliferative stage of diabetic retinopathy. Intravitreal injections of vasoproliferative factor inhibitors also used. And here you can see the process of intravitreal injection, intraocular injections of vasoproliferative factor inhibitors or anti-VEGF factors, anti-VEGF therapy. I will return to the previous slide, 1 second, 14. Here on pictures, you see on the left picture the result after laser coagulation of the retina in first hours after laser coagulation. You see the white spots, it is laser. And on the right picture, you see the result of laser coagulation in time more than 1 week, 2 weeks, and you see something like little scars on the place of laser coagulation, scar spots. We need to use laser coagulation of the retina, pan-retinal laser coagulation, to stop the neovascularization process. and to stop the ischemic process. Okay, next. Next is central retinal artery occlusion. What about central retinal artery occlusion? I can say that it is something like stroke, but inside the eye. It is a disease where the flow of blood through the central retinal artery is blocked, occluded. It occurs in patients with hypertensive disease, in young people suffering from endocarditis, for example, heart diseases, chronic infectious diseases. In clinical picture, one eye process, mostly, occurs suddenly, accompanied by a painless loss of vision in a short period. Uh-huh. I return. There were problems in internet. Do you hear me?
Yes, Urban.
Yes, ma'am.
Good, good. Uh, Arteries are sharply narrowed to interrupted blood flow. The veins are not changed. So in the picture we can see very pale part, very pale central part of the retina. It is due to the swelling process in the retina. And we see something like a red spot in the central part on the place of fovea. On the place of fovea. We see veins, but not see arteries in this area. They are very, very narrowed. Clinical picture ophthalmoscopically against the background of white clouded retina, a dark red central fossa. Here you can see it too on this picture. Is clearly distinguished. This symptom has a name of cherry bone, something like a cherry bone on the central part of the retina. This is due to the fact that in this zone there are only 3 layers of nerve cells, and the intermediate layers of the retina are absent. So the retina in the central fossa doesn't swell and looks red. So anatomically we know that in retina there are 10 layers. 3 main layers with nerve cells, and other layers is intermediate layers. In central part, in fovea, in central fossa, in fovea, there are only 3 nervous layers, only 3 layers with nerve cells, and there are no intermediate layers. And in other part, yes, you want to ask something? Sikandra Chandra or not? Not. Okay. So, due to the absence of intermediate layers in the central fossa in fovea, it doesn't swell. It doesn't swell. But other part of retina become swelling. So it is swelling. It's not. So what we see it the same red. Other part is very pale due to swelling. So it is named symptom of cherry bone. It's not hemorrhage. Treatment. About treatment. Should be urgent, of course, and begin immediately after diagnosis. Something like a stroke, but in the eye. Medicines: vasodilators, anticoagulants, thrombolytic drugs, laser treatment in the early stage. The outcome of the disease is unfavorable in most cases. In the outcome, atrophy of the optic disc develops. So, about the study of treatment, and it must be in 6 hours after start the disease as a stroke. And if it is, for example, after one one day, 2 days, of course, the outcome of the disease will be unfavorable. The next disease of vessels of retina. It is central retinal vein thrombosis. It occurs in elderly people with hypertension, atherosclerosis, hemostatic disorders, chronic sepsis, etc. Clinical picture. Process more often one eye, but can involve the second eye over time. Ophthalmoscopically, there is a symptom of a crushed tomato. The right picture is something like this symptom of crushed tomato. It is the central vein thrombosis. In the left picture, we see the thrombosis of one brain of only one vein, not the central, but only part of the veins. So not all retina with hemorrhages, but here all retina with hemorrhages of the right, and it looks like crushed tomato. Also clinically, the optic disc is edematose. Dark red, borders distinct. Multiple hemorrhages on the disc, near the disc, and near the vessels. Veins are dark, dilated, tortuous, arteries narrowed. Typically, the presence of numerous bar-shaped and large hemorrhages along the vessels. A lot of hemorrhages along the vessels. Perhaps the presence of plasma-ray and exudates. In the long term, maybe neovascularization and secondary glaucoma due to neovascularization. But it is in long term, it's not in acute period. It's the central vein thrombosis. It's a part of one branch of the central vein has thrombosis, only the part. So if we have only the venal brain thrombosis, central retinal vein thrombosis of one brain, the optic disc, will stand normal. But if we have central vein thrombosis, the disc is involved too. The next. And about treatment of central vein thrombosis. Do you see the slide? Oh, yes, I see too. Okay.
Yes.
Treatment of vein thrombosis should start in the first days, not first hours, but first days from the beginning. We use several medicines. It's fibrinolytics, direct and indirect anticoagulants, vitamins, and enzymes. Combinations of intravitreal injection of anti-VEGF drugs and laser coagulation of the affected area of the retina is used. So here you see the retinal vein thrombosis participle of the one branch of the central vein. It is only one branch. In treatment, we use mostly in the acute period fibrinolytics, anticoagulants, and a little bit later we can use intravitreal injection of anti-VEGF drugs and laser coagulation of affected area. Next. The next disease is not acute disease. It is mostly chronic disease. It is retinal pigment abiotrophy. It is trophic disease. These dystrophic diseases, it's not inflammation. Um, you can see the name retinitis. It is all the name of the retinal pigment abiotrophy. It can say you that there is some inflammation in the retina. No, there is no inflammation. It is non-correct word in modern history, but it is used sometimes too. New version is retinal pigment abiotrophy. But you can find in tests, in exam, retinitis pigmentosa too. Be careful. Is a dystrophic retinal disease with a family hereditary tendency and a characteristic long-term and progressive course. Some clinical features of it. The weakening and loss of vision, night blindness. It is one of the first main features, night blindness. Decreased visual acuity, concentric narrowing of visual fields, a sharp decrease in the caliber of retinal vessels. Nearby the retinal vessels, starting from the peripheral part, not in the central part, but in the periphery part of the retina, specific pigment deposits of dark brown color are formed. Something like this. They resemble bone corpuscles, something like bone corpuscles of various shape. As the disease progresses, their numbers increases and spreads to the center. The optic disc is pale and waxy. Characteristic changes in the macula bronze reflex. Of course, we have peripheral dystrophy of the retina. It is progressive till central part of the retina, and the patient lose one of the main functions of the eye. It is visual field. Visual field is losing from the peripheral part to the central part with the retinal damage too. Here you see the full retinal picture with peripheral part and with central part in the case of pigment abiotrophy. Here too, mostly the central part. It is a live part of the retina, yet it is dystrophic part with retinitis pigmentosa. What about treatment? There is no specific treatment. We cannot treat it at all, only symptomatically, and try to stop ischemic process, dystrophic process. Aimed at expanding the vessels of the retina and choroid. Metabolic and trophic therapy, vitamins only. Next disease is one of the severe diseases of the eye. It is retinal detachment. Why it is so severe? It's not inflammation. Why it is so severe? Because retina is one of the main part due to the visual functions, visual field, visual acuity, and our visual analysis starts in the retina. And retina has its nutrition not only from vessels but from choroid. And if there is a retinal detachment, retina lose its main point of nutrition and become necrosis. And so when the retinal detachment there is for a long time, this part of the retina will not work ever. Okay, retinal detachment is a separation of the retina from the choroid due to the accumulation of fluid between them. It disrupts the nutrition of the outer layers, as I said, of the retina, which leads to rapid loss of vision. Retinal detachment can be rhegmatogenous or degenerative. It is primary variant of retinal detachment. Can be traumatic and also secondary due to exudative process or tractional process. Let's speak about each variant. But firstly, I want to remind you that I will give you the chance to write your names in comment chat uh, to check your presence on the lecture. Please don't write your names now. It will not be uh, checked in summer result. Only when I tell you that I check your presence on the lecture. Only when I tell you. Not now, not now, when I tell you. Okay, retinal detachment. First variant of retinal detachment is degenerative or primary or rhegmatogenous. It is degenerative detachment uh, arises in connection with a rupture or tear rupture. In the picture you can see here the tear in the retina or rupture in the retina. So, guys, don't write your names now. I will give you a chance a little bit later. Okay, we have a tear or rupture in the retina. Through this rupture, the fluid from the vitreous body, the aqueous humor, the fluid from the vitreous body comes between the retina and choroid, and process of detachment starts. The next variant, traumatic. It develops as a result of direct trauma of the eyeball, contusion, or penetrating injury. Here you see clinically the picture, the photo of the retinal detachment. Total retinal detachment. It is an optic disc. It is the vessels of the retina. Retina is detached. Not like here, for example, there is a part of the retina which don't detached, little part, and other parts are detached. Secondary retinal detachment or exudative retinal detachment. It is a consequence of various diseases of the eye. Mostly these diseases are tumors of the choroid and retina. Also it is uveitis and retinitis. Such diseases cysticercosis, vascular lesions, hemorrhages, diabetic and retinal retinopathy, thrombosis of the central retinal vein. Retinopathy of prematurity and sickle cell anemia. Also hypolendoangiomatous, Coats retinitis, and etc. Mostly we see secondary. You want to ask something? No, thanks. Mostly we see secondary retinal detachment after tumors of the choroid, less in retina, and less in inflammatory diseases of these structures. What about complaints in retinal detachment? The sudden appearance of loss in the field of vision, loss of the field in the field of vision, designed by the patient as a veil or curtain in front of the eye, which progressively increase and lead to an even greater reduction in visual acuity. These subjective symptoms may precede the feeling of flashes of lightning, it named photopsias. The curvature of the objects, metamorphopsia, floating cloud, due to changes in the vitreous body. What about treatment? Treatment in of retinal detachment is only surgical anymore, only surgical. Also, during the surgery and after surgery, laser coagulation is used. Um, without surgery, big surgery, laser coagulation can be used only in a small local retinal detachments, very small. We can use two variants of surgery. It is episcleral surgery. It's the first picture, left picture. It is plombage or ballooning of the sclera in the projection of retinal rupture or encircling techniques. Scleral buckling. It is buckle pushes eyeball against the retina. It is circle round all the eye. We can use only local variant of this plumb only in the projection of retinal rupture. After this surgery, we need to use laser coagulation, transpupil laser coagulation, the next day, the next week. And the second and most common today surgery is intraocular surgery. Intraocular surgery. It is pars plana vitrectomy with use of various substances of tamponade, mostly silicone tamponade. Rarely we can use also air tamponade with sterile air or gas. The next disease is due to optic nerve. It is papillitis. Or papillitis, optic neuritis or papillitis. It is inflammation of the intraocular part of the optic nerve. Main reasons for this inflammation. It is inflammatory diseases of the brain and its membranes, inflammatory diseases of the eyeball and orbit, diseases of ENT organs, acute and chronic common infections. Also, general toxic and allergic diseases. You see that it is common inflammatory diseases of organs near the eye and also in the body. So, neuritis or papillitis, it is something like an inflammatory answer to other inflammatory diseases in our body. Clinical picture of optic neuritis. It is a hyperemia of the optic nerve disc. Its borders swollen, exudate in the vascular funnel of the optic nerve. Moderate expansion of arteries, tortuously of lens. Significant reduction of the visual acuity, narrowing the boundaries of the field of vision, of the visual field, violation of color perception. So, the main functions of the eye, visual acuity, visual field, color perception, light perception, little, are changed due to this inflammatory process. What about treatment? Of course, it's anti-inflammatory treatment. It must be used immediately. Non-steroidal and steroidal anti-inflammatory drugs. It's not only eye drops. Of course, we need to make injections, parabulbar injections, and intravenous injections, intramuscular injections, and use oral medicines too, due to differences in clinical picture individually. Also, detoxification, dehydration, reflex therapy. Etiological treatment. After finding out the reason, we can start the etiological treatment. And the outcome of this process is partial atrophy of the optic nerve. Partial atrophy of the optic nerve. The next variant of neuritis, it is retrobulbar neuritis. It is an inflammatory process in the part of the optic nerve after the eyeball and before the chiasm. You remember that there are several parts of nerve. The papillitis, the previous disease, is due to the intraocular part, and retrobulbar neuritis is due to the part between eyeball and chiasm. It is intraorbital part, intracanalicular part of optic nerve. What about clinical picture? It is reduction of the visual acuity of various degrees. It can be very little and it can be very big. Narrowing of peripheral boundaries of the field of vision. It can be a central scotoma, central loss of visual field. On the picture here, you see the normal view of fundus, the normal view of retina and optic disc. In Russian, who cannot read, I try to translate. Here you see the phrase that the patient see nothing and the doctor see nothing. It means that we cannot see any changes on the fundus, on retina, vessels, optic disc. It looks like normal because the problem is behind the eyeball. But problems with visual field, with visual acuity, of course, is coming because optic nerve suffer. There are two variants of retrobulbar neuritis. It is acute and chronic. Acute variant, repeat onset with pain in the depth of the orbit and the movement of the eyeball. It is specific feature. Problems with moving, problems with pain moving of the eyeball. A rapid drop in visual acuity. And what about chronic? It's slow, gradual development of all symptoms. It can cause by basal leptomeningitis, multiple sclerosis, general intoxication, viral diseases, diseases of the paranasal sinuses. Very often it is viral diseases. Treatment depends on the etiology of the process and, of course, anti-inflammatory drugs when we try to find the reason. Both non-steroidal and steroidal variants. Okay, when we start the next part of the lecture, we need to check your presence. I put start. Now you can write your names in chat and you have 5 minutes. Now it is 15 and 44 hours. In 5 minutes, we will start.
Doctor.
Yeah.
Good evening, Doctor. Doctor, today is last lecture?
No, the last lecture will be next week. We have 8 lectures. 8 lectures at all. Okay. You write your names. I start to speak about papilloedema. Papilloedema or stagnant optic disc, edematous optic disc. Something look like neuritis, papillitis. No, it's stagnant optic disc. What is it? It is a development as due to increased intracranial pressure. Increased intracranial pressure. What are it is can caused by tumors, brain abscesses, inflammation of the meninges, skull fractures, aneurysms of central vessels, etc. So some problems which can increase the cranial pressure, intracranial pressure. What complaints? Complaints of vision, not as a rule. There are complaints of a headache due to the main reason. Sometimes the patient can complain on a vision, on that they lost the vision, but it's not so common. Papillary edema ophthalmoscopically. The optic disc is enlarged, penetrates into the vitreous body. The disc color is pinkish gray. The bodies are fuzzy, non-clear, blurred bodies. There is no oxidate in the vascular funnel. The veins are sharply expanded and twisted. The process is usually in both eyes, of course. Very rare, we can see this process only in one eye. Why? Because of the volume processes before chiasm, but mostly it is two eyes, both eyes. For organic pathology, for tumors, will also be characterized by changes in visual fields. For example, hemianopsia or local scotomas in visual field. Papillary edema has 4 stages. In the end of them, the atrophy of the optic disc develops. About treatment. It is aimed at the underlying disease. Papillary edema don't need specific local treatment because we need to treat the main disease which caused this problem, which caused the increasing of intraocular pressure. Optic nerve atrophy. After all pathological processes of optic disc, of optic nerve, the optic nerve atrophy comes. The causes, as a result of inflammation, edema, compression, damage, degeneration, all different pathological processes of optic nerve fibers of vessels feeding it. Clinical signs. Blanching of the optic nerve head, a sharp contraction of blood vessels. So the optic disc is pale and it's pale and sometimes it's white color. Okay. The optic disc atrophy can be two variants, primary and secondary. What time is it? 15 and 49 minutes. 5 minutes is over, so stop taking your presence. But speak about optic nerve atrophy, primary and secondary. What about primary atrophy? The boundaries of the optic disc are clear. Boundaries are clear, even sharp. Secondary atrophy develops as a result of hypertensive neuropathy, neuritis, stagnant optic disc, and as you remember, in these pathologies, boundaries are swollen or they are not clear, they are blurry. And boundaries of the optic disc in optic nerve atrophy will be blurred. It's characterized by changes in visual fields. They are very different depending on the localization of pathological process. These questions there is in your exam, ophthalmological exam, about primary and secondary atrophy of optic disc, and main difference between these two variants is the kind of boundaries of the optic disc, clear and blurred. clear and not clear boundaries. And last but not the least theme of the pathology of the retina and optic disc, it is tumors. Tumors as for retina, we can speak about one main tumor. It names retinoblastoma. Retinoblastoma is malignant congenital tumor derived from retinoblasts, most common intraocular tumor in infants, children. In 70%, it is unilateral. It can be in one children from 50,000. It has no racial or sexual prediction. It can metastasize and be fatal in detected too late. Survival rate 90% and more if detected early. Typical age of diagnosis is around 18 months. There are two types of retinoblastoma, inherited and sporadic. Inherited variant, less than 10% of cases. Can be multifocal and bilateral. Sporadic one is unilateral mostly. It is retinoblastoma on the fundus with little retinal detachment. You know about the reflex from the fundus. If we look through the pupil, we see the pink in normal pink retinal reflex. If the patient has retinoblastoma, the reflex from the fundus become white, and it's named leukocoria. Leukocoria, it's one of the main symptoms and very specific symptom to retinoblastoma. The reflex from the fundus become white. If the retinoblastoma big and takes the central part of the retina, this eye will have very poor visual acuity, and due to it, it will be amblyopic eye and can cause strabismus. If the optic nerve is involved, it can be ominous. Many treatment options depending on multiple factors. It can be chemotherapy, but it's very rare used due to specific individually. We need to wait a little. I cannot open the picture. 39. As for genetics, retinoblastoma severe with inherited type have 50% chance of transmitting to their children. If parents are healthy, they have one child with retinoblastoma, they have 6% chance of another. If there are two or more children with retinoblastoma in healthy parents, they have 50% of another children with retinoblastoma. What about treatment options for retinoblastoma and for intraocular tumors in common? It is brachytherapy. It is radioactive plaque. requires two surgeries and sometimes a hospital stay, of course, because the first surgery is needed to locate the radioactive plaque on the sclera, and the second to take it off. Systemic radiation or chemotherapy if there are metastatic disease, if there is a metastatic disease. Also, we can use the local treatment, something like photocoagulation, cryotherapy, transpopular thermotherapy, TTT, transpopular thermotherapy. And if there is a very big retinoblastoma, we need to do enucleation of the eyeball. We need to do the enucleation of the eyeball. So, for today, that's all.
Thank you so much,
You are
madam.
now unmuted.
Thank you for your
You are now
attention.
muted.
I want to say that today, the next week will be the last lecture. I wait